welcome to our continuing series of presentations on various subjects surrounding the improvement of undergraduate medical education in substance use disorders. These presentations are being made available through COPE, the Coalition on Physician Education and Substance Use Disorders, and funding is by the Opioid Response Network. COPE is a voluntary organization whose mission for the past 15 years has been devoted to improving patient care and the public health by ensuring that all rising physicians are trained to prevent, identify, and provide specialty-appropriate interventions for patients who engage in unhealthy use of alcohol and other drugs, including non-medical use of pharmaceutical medications. This presentation is on infiltrating an understanding of prevention, identification, and treatment of comorbid substance use problems during a student's clinical psychiatry rotation. Today's presentation will be in the form of a moderated discussion led by Dr. John Renner. Dr. Renner is a professor of psychiatry at Boston University and a former president of the American Academy of Addiction Psychiatry. He has also been a COPE member for a number of years. Dr. Jungjin Kim is the medical director of Alcohol, Drugs, and Addiction Inpatient Program at McLean Hospital and is an instructor of psychiatry at Harvard Medical School. He will also be joined by Dr. Hilary Connery, also a COPE board member and an assistant professor of psychiatry at the Harvard Medical School. She is the clinical director of McLean Hospital's Division on Alcohol, Drugs, and Addiction. She has also been involved in various activities with the AAAP. She has published some insightful works on today's subject of enhancing the awareness of comorbid substance problems and mental health during a student's psychiatry rotation. Dr. Renner, the microphone is yours.
Thank you very much, Steve. We are very pleased to be with you today. We're hoping that this presentation will be useful in terms of how any hospital setting that has psychiatry experiences for medical students would be able to incorporate addiction treatment information and the care for addictions into that program, even without having expert addiction psychiatrists on their staff. So we're hoping that this is going to be a useful presentation in a variety of settings. And we'll look forward to hearing from the people at McLean who have been running educational programs for residents, fellows, and medical students for many years and have rich experience trying to make these useful learning experiences for their trainees. Do you want me to start with Dr. Kim, or do you want to start, Hilary? Who would like to go first?
I think we could just go to the next slide. Let Jungjin control the slides.
Okay, well, thanks for joining us. So we built this slide deck for the psychiatry services that don't have an embedded addiction psychiatrist. And the goal is really simple: to make substance use disorder care reflexive and not optional, so your teams can identify, stabilize, and start evidence-based treatment seamlessly. We do not have any disclosures, no conflicts of interest. And like Dr. White had introduced us, I'm joined by Dr. Connery, my colleague here, who's the clinical director. And we'll start with a brief teaching framework, then walk you through tobacco as a mini model that you can kind of copy and paste to any substances, and finish with pragmatic alcohol use disorder care. About how to triage the patient, how to manage withdrawals, how to do pharmacotherapy or medication management, and some quick vignettes along with some psychosocial treatment introductions. And as we go, think of one patient from this week who may have benefited if your unit or your program did a single thing differently. So just a note about how we teach. So we have a couple different suggested framework for learning. And number one is embedding the education. And what I mean by that is that we embed micro teaching inside existing huddles or rounds. For example, 1 5-minute pearl per week at rounds. And that could be as simple as something like COS scoring or how to start varenicline or these medications for tobacco use disorder. And keep it under 30 minutes for any formal session. That is to optimize the attention and retention drop after that. And operationally, we would wire prompts into the admission and discharge workflow, like opting out of NRTs or nicotine replacement treatments, and for admission and discharge prompts for alcohol use disorder medications. And lastly, also good care becomes the default. And when we track these key performance metrics on a regular basis. So for example, if we track things like percentage of individuals who are eligible for offered pharmacotherapy or medications, what percentage did accept the medications or proposed treatment? And what was the rate of 72-hour likely 72-hour return to the emergency rooms? Those numbers tell you if the education is changing practice and the outcomes. So these are just some of the things that we recommend as important teaching framework to guide addiction treatment and education. And having said that, with the teaching principles under our belt, let's move on to the next session in which we talk about treatment principles. Hilary?
Yes. First bullet, please. If there's one message that you take home from this webinar, we hope that it's this one: the importance of treating the whole person and not just looking at somebody for treatment of target symptoms that are being presented. So we really want holistic care. And Jungjin, if you could just hit the bullets for me, that would be useful. So things like considering the fund of knowledge that the patient has about what their health risks are and being able to provide education on that. Eliciting stressors and supports that can impact a patient's motivation to change, and engaging in problem-solving strategies with them in a collaborative way. Considering what the current capacity is for change, because, for instance, if you're on an inpatient psychiatric unit and you have a patient, you're working with a patient who's severely psychotic or acutely manic, they probably aren't going to have the capacity to make a lot of important decisions in that moment and will need to stabilize a bit before you use your interventions. So being sensitive to where the patient is in their recovery process and their capacity for change. We also want to normalize ambivalence about change, especially changes that are hard to make. And certainly when we're talking about addiction and substance use disorders, making change in these areas is very challenging for many patients. So we understand that it's natural for them to feel both that they want to change or they know they need to change, and yet that it's very difficult to change, and there may be some resistance to that. We work with that. Some of the ways that you work with that is using a motivational interviewing framework, and for instance, a strategy such as ask, offer, ask, which is a way of highlighting that you're asking the patient to share with you information about their understanding of their health risks and their willingness to receive education. If they're willing, you would want to ask permission, such as, if we're talking about tobacco reduction, for instance, how much do you know about medications to treat tobacco use disorder? May I share some information with you about what might be useful? And then asking again when you've had that conversation to make sure that the person really understood the information that you're providing to them. So that's the quick ask, offer, ask. This is a nice paradigm and strategy to teach medical students because it's broadly useful even in other medical environments. And then the goal is to align on a near-term goal. So hopefully at the end of your conversation, even if it's simply, I agree to think about this and we'll talk about it again at our next meeting, that's good. That's a near-term goal. So number 2 is using harm reduction, which harm reduction sometimes is misunderstood in the way that it's presented. Harm reduction does not mean that anything goes, that all actions are permissible. Harm reduction really is talking about the specific health and safety risks and working collaboratively with somebody to structure a risk reduction plan. And so we think about with alcohol use disorder, patients generally do understand that they should not be driving if they are intoxicated, and they should wear their seatbelt. These are 2 very simple harm reduction interventions that really, are a basic framework for what we're trying to do, a clear behavioral plan that is involved with risk reduction and not necessarily addressing the problem of maybe this person is drinking at a level that's unhealthy for them. You're just looking to reduce the harm in that moment for somebody who's not ready to change. And then number 3 is really using safety and reduced health risk as your ethical anchor. So trying to neutralize the conversation, trying to be sure that the information you're delivering isn't being perceived as a personal judgment or your personal advice. You want to use language such as, I understand that it can be difficult to quit smoking, yet the safest thing for your health would be to stop smoking. Would you have any interest in talking more about this? So really highlighting safety rather than any kind of just general advice. And leading with reducing risks as a step 1 and then building toward long-term recovery and wellness. Next slide, please. So we really like to use tobacco reduction efforts in psychiatry settings because it's not a very sensitive or threatening content area, and it does provide a mini model that can be generalized to addiction care, but it's one that's quite easy to do and easy to learn and brief. It's really a brief intervention. So it's perfect for introducing medical students to how addiction care is delivered. And when we talk about tobacco reduction, we're first going to teach that current practice guidelines emphasize that you provide a medication offer to the patient as a default. And next, please. With the medications, we know that among the 3 FDA-approved medications for tobacco cessation, varenicline is first line. It's considered the most effective. And we also have nicotine replacement therapies that come in many different forms, as well as bupropion, which is also known as Wellbutrin. So educating a patient, even one who is not ready to stop smoking, that actually starting a medication while you continue to smoke can be a first step towards reducing your risk. And many patients who successfully start medication will go on to make changes, whether that's setting a quit date or simply reducing the amount that they are smoking. You have a brief engagement model. Again, here's an opportunity to practice the ask, offer, ask motivational interviewing strategy. If somebody is willing to think about quitting, it's important to talk about setting a quit date. And quit dates are often scheduled, if the person is starting a medication, to be set for 7 days after the start of that medication. Presumably at that time, the medication will be at full dose and the patient is in the best position to be able to stop smoking at that point. If the patient is discharged and is being seen in outpatient care, a follow-up within a week or 2 would be ideal. For patients that you are following on units, it's great to check in with them every day about how their efforts are going and whatever the plan is to try to tweak that to optimize it. And 3, in inpatient management, by default, patients are prescribed orders for nicotine replacement therapy if they are smokers, and they have to opt out if they don't want it. This ensures that everybody gets offered the medication and encouraged, also has the opportunity to have education about it. Many patients really will accept this because they're a lot more comfortable on it. Next, please. When you're doing tobacco surveillance, it's also important because of the co-occurrence quite frequently that patients will either be using vaping tools, whether that's for tobacco or other substances, and any forms of cannabis use. And so vaping tobacco generally can be treated identical to cigarette smoking in terms of the interventions. Cannabis, of course, a lot harder to treat because we don't have FDA-approved and highly effective medication interventions for that. So there you're going to be looking at more education, risk reduction, and cognitive behavioral therapy interventions. Importantly, you really want to work with patients to align with what their own goals are. So here we just share some quick protocols that students can learn very rapidly. And if you would just put them up, thank you. So the titration recommended for varenicline is 0.5 milligram by mouth daily for the first 3 days, and then increase to 0.5 milligram twice a day for the next 4 days. And finally, 1 milligram twice a day as tolerated. Titrating this more slowly is important because many patients will experience significant GI side effects if it's titrated rapidly. So be screening for that. With nicotine replacement treatment, a 21 milligram patch is appropriate for anybody who is smoking at least 10 or more cigarettes per day. And you can use a smaller dose, 14 milligram. There's also 7 milligram for anybody who's considered a light smoker. It's also true that among patients, say with psychotic disorders, who are often 2 to 3 pack a day smokers, that you can safely use more than one patch in those instances. And you're basically matching the dose of the nicotine replacement with the rough dose of nicotine that they're receiving from the cigarette or the vape. In addition to that, layering the long-term nicotine replacement patch with an immediate acting nicotine replacement solution such as gum or the nicotine lozenge, that's a very highly effective way to help patients to minimize cravings and other symptoms of withdrawal. And so using 2 to 4 milligrams as needed when they're having breakthrough cravings is very helpful. Sometimes you can put that on a fixed schedule as well for more dependent smokers. With bupropion, we generally recommend that you use the sustained release formula at 150 milligrams daily for the first 3 days, and then if tolerated, increase to twice a day. And this is because bupropion can be quite activating and it can make people feel almost over-caffeinated if you dose it too quickly. We must avoid dosing bupropion in people with a history of seizures or eating disorders, and also be careful to screen for bipolar 1 disorder because sometimes antidepressants can create an acute hypomanic or manic episode. And then finally, when it comes to quitting smoking, it's important to be aware that some medications, especially clozapine and olanzapine, can have their blood levels increased after tobacco cessation. And the reason for that is they are metabolized by one of the liver enzymes in the P450 cytochrome family, CYP1A2. And tobacco is a strong inducer of this enzyme, which means that while you're smoking, the enzyme is more rapidly metabolizing the medications. But if you suddenly take away that inducer effect by quitting smoking, your enzymatic metabolism is slower and the levels of these medications can increase. So it's recommended in those cases that you would follow up with levels to make sure that they're still in a good therapeutic range. Next slide. Dr. Kim, you can take it from here.
Yes. So having covered tobacco use disorder, we now segue to alcohol use disorder, another very common psychiatric or addiction that is encountered in our setting. So a couple of different points. The important informations are that first, the most critical piece is making sure that we triage. So initial assessment for the likelihood of withdrawal, and that will determine the level of care to which the patient will need to be placed. And after that, if the patient needs to undergo withdrawal management, we cover the aspects of withdrawal management, and also pharmacotherapy and psychosocial treatment that undergird alcohol use disorder treatment, no matter which phase the patient may be in. And then we finish it off with a couple of vignettes to highlight some of these points. So let's start with the triage. So with the triage, some of the things that typically go through my mind and should go through your mind as you are assessing the patient should be, what is the likelihood of this individual in front of me having a severe withdrawal? And some of the predictors of severe withdrawal include the following: heavy use, prior serious complications of withdrawal, for example, delirium tremens, or seizures from withdrawal. Because alcohol is a central nervous system sedating medicate, has a sedating effect on the central nervous system. Once you take away that sedating effect with cessation, you can have a surge in your adrenaline, your noradrenaline, and all of these things cause a hyperadrenergic storm, which can cause issues like seizures and high blood pressure and tachycardia. Last drink is also important to know because that gives you a window of where the patient might be in terms of the risk for withdrawal, and if the patient should be, if we should be worried about further withdrawals, or if the patient might be safely outside of that window. Vital signs give you a proxy marker for the level of autonomic instability and how severe the hyperadrenergic storm that comes from taking away the alcohol might be. Comorbidities and polysubstance, if there are other substances that are involved, or if there are other psychiatric conditions that we need to take care of, that needs to be taken into consideration as we think about the overall severity of the presentation. And then all of these things inform whether we decide to recommend if the patient might be safely managed in an outpatient setting alone, versus should we send the patient to an inpatient setting or even an ICU level of care. And of course, give the thiamine early, and never hurts to give the thiamine early because it's water soluble, and that should be offered to any patient at any level of care. Once the determination is made in terms of the level of care, the next step is, in the case that patient may need withdrawal management, how do we do it? There are a couple of different ways of doing withdrawal management. One is commonly encountered in many settings called symptom triggered, and that is basically you are monitoring for symptoms based on certain scores like the COS scores, and you're giving medications like the benzodiazepines, lorazepam, or diazepam based on the protocol. And typically it's about lorazepam 2 milligrams every hour as needed based on severity of the COS score. And depending on where you score, it gives you a sense of how severe the withdrawal symptoms are. If the scores are high, you give a little bit more, 4 milligrams. If the scores about 8 to 10 or more, you give about 2 milligrams. And you keep dosing it in that way until the scores drop. The other method in which you can manage the withdrawal are either fixed or front loading. And these are typically used when the capability to monitor the patient is really limited, or if the patient is at high risk from the get-go based on the risk profile that are outlined in the previous slide. So in which case, the patients are given lorazepam 2 milligrams about every 6 hours for about 24-hour period, and then tapered off. or diazepam 20 milligrams every 1 to 2 hours, and then that's given for 3 to 4 times, and then given as needed subsequently thereafter. So you're basically giving them a lot of medications from the get-go, with the understanding that potentially the patient could get a little bit sedated with a little too much of the medications. So you do have to monitor for sedation and potentially falls as well. But typically, the rule of thumb is that once you fall behind on that window of withdrawal management, it's very hard to catch up. So you want to make sure that you adequately dose the patients with benzodiazepines early and adequately. Some of the order sets that goes into withdrawal management needs to have certain factors, including how frequently are you going to monitor the patient for withdrawal using the CWA? What are the holding parameters? For example, what's the respiratory rate? What are the level of sedation? Because these medications can cause sedation, you do have to have those parameters specified. Thiamine before glucose to prevent Wernicke's, checking the electrolytes, and having the seizure and fall precautions throughout. Medication is also recommended for alcohol use disorder patients, and typically there's no quote-unquote right timing, but there are certain nuances that come with each of the medication that could be offered. And as we know, there are 3 FDA-approved medications for alcohol use disorder. One is the naltrexone, second one is acamprosate, and third one is the diazepam. And for example, if the patient wants to simply cut down or have a lot of cravings, a medication that could be thought of as the first line for that might be naltrexone. It's an opioid antagonist that somewhat silently works in the background to cut down on the cravings and dampens down the alcohol priming effect. Alcohol priming effect is that effect in which if you drink that first drink, it reduces the likelihood of needing to reach for the second and the third drink. So you can dose it 50 milligrams daily or given as an extended release 380 milligram injection on a monthly basis. And you do have to look at the liver function test, and the individual needs to be opioid free for at least 7 to 10 days, as it is an opioid antagonist or blocker. In the case that the patient might want to sustain abstinence or may have liver disease that may preclude the use of medication like naltrexone, an alternative might be acamprosate or Campral, 666 milligrams 3 times daily, and is typically renally adjusted. In the case of patients who are highly motivated and wanting abstinence, and typically in a supervised setting where somebody can oversee or provide some sort of structure around the medication, diazepam, 250 milligrams might be a good option. And the dose ranges can vary from 125 milligrams to about 500 milligrams. Now, it does require some informed consent because it does come with some side effects, including things like psychosis, as well as the adverse effect that comes from taking the medication and drinking, because this works in a way that if you take the medication and if you drink on top of that, it can cause a serious adverse reaction, and it works as a behavioral deterrent against drinking. And then there are some off-label options as well, in addition to the 3 FDA-approved options. One option would be gabapentin. Gabapentin can offset some of the withdrawal symptoms, as well as has a tendency to reduce heavy drinking. And it can be started at 300 milligrams 3 times daily, and then dosed up to 600 milligrams 3 times daily. And then another option would be topiramate, another anti-seizure medication that can be dosed started at 25 milligrams at nighttime, and then as tolerated, titrated up to 100 milligrams to 200 milligrams per day. And then with all that, always give thiamine. And in the case of high-risk patients, IV or parenteral thiamine is indicated. Folate, multivitamins, and always starting medication for alcohol use disorder prior to discharge. And then here are some peer support and self-help slide deck. Hilary? I think you're muted.
Thank you. Sorry. Peer supports are just so important because, in part, they're accessible to patients where many other types of supports may be harder to access. When we think about peer support, and sometimes we use the term mutual help, we're talking about 12-step programs such as Alcoholics Anonymous or Narcotics Anonymous, and we're also talking about non-12-step programs such as Smart Recovery, which is a self-management paradigm based on cognitive behavioral therapy for regulating drinking. There are others as well, but those two are main ones that have been looked at and studied and demonstrated to be highly effective for patients who engage in them. So they're free. They are accessible at different times of day. And one resource that's really helpful to know about if you're looking for meetings besides the websites, both AA and other 12-step programs and Smart Recovery have online websites where you can find meeting locators and you can have access to educational materials. And also there are virtual groups. But there is another platform that's really worth exploring, and I encourage medical students to look into this, and that is the www.intherooms.org. In the Rooms provides peer supports of all different types, and they have them running virtually most of the day. So they're really helpful for many different kinds of problems, including behavioral addictions, and they're virtually accessible at many different hours of the day, so convenient. So these are great adjuncts. They're not meant to be standalone necessarily, although some people have successfully used them as standalone care. But typically in medicine, we think of them as important peer support adjuncts to professional care. And how do they work? I mean, a lot of it is there's teaching in it, teaching you how to reduce or stop using a substance that's problematic. But there's also the community engagement. There's developing a recovery network, meaning that you can do things and have leisure activities with other people who are similarly not wanting to engage in any kind of risky behavior. So that piece is very important. Helps people to transition into a recovery mode much more easily than trying to do it on your own and kind of find your way around to people who won't pose a risk in your environment. And, you know, we encourage everybody to try them out. They're not mutually exclusive. You can go to 12-step and Smart Recovery. Many people use that successfully. But try a lot of different meetings and see what strikes you. I will tell people when they're starting 12-step for the first time to go first to a beginner's meeting because those are designed specifically to help orient people, and the other people in the room will also be beginners. So it's a very useful way to start. Next slide, please. Okay, Dr. Kim, these are yours.
All right, so having said that, we covered both tobacco use disorder and alcohol use disorder. Let's just try to plug it into some vignettes. So first vignette is an individual with schizophrenia and who is smoking a pack a day. So just kind of putting together what Hilary had taught. Let's start with the first thing that should come to our mind would be starting the medication. What's the role of medication here? So think about offering some of these options. Use the ask, offer, ask principle. Is it okay if I share some of the information about medication? Oftentimes medication is helpful for people to help them come off of the tobacco? Is it okay if I share? And then you give the information such as varenicline and NRTs, bupropion, and so forth. Think about starting varenicline today, and inpatient, if it's in an inpatient setting, a patch, 21 milligrams plus minus 4 milligram gums and lozenges as needed on top of that. And, discuss the quit date. If the patient is motivated for quitting, set a reasonable quit date and then schedule the checkup afterwards. If the patient is interested in a much more slower taper rather than a set quit, discuss with the patient, have a dialogue with the patient about what might be a reasonable plan. And then, of course, adjust the antipsychotic, such as Clozaril or olanzapine, if the patient is taking that medication, because that will have an impact if the smoking stops because of the effect on the enzymatic metabolism of the antipsychotic medication. Another vignette, a quick one that you can also plug some of the things that we discussed. Let's just say this individual is 12 hours post-drink and is presenting with high CWA score of 16. So what do? So first is triaging. So is this individual at high risk for withdrawal? So you can see from the time course, yes, still within the withdrawal window. And the CWA score is quite high, indicating that patient is in active severe withdrawal. So the likelihood that the patient this patient will not be managed in an outpatient setting, most likely will need to be in an ER or in an inpatient setting. And I would think about immediately giving a dose of lorazepam or another benzodiazepine, and preferably IV, 2 to 4 milligrams, and then check the CWA score hourly to make sure that the score goes down. And of course, the next step would be giving thiamine, preferably parenterally or IV before glucose, making sure that fluids are repleted, and magnesium and potassium to be checked and repleted as needed. And if the CWA score or the withdrawal symptoms are not dropping at least 50% within the next 60 minutes, then consider increasing the dose and treating the withdrawal symptoms a little bit more aggressively, and even consider monitor bed, like an inpatient unit or an ICU setting for more aggressive management. And of course, if in doubt, consult with your colleagues or your attendings to see if an escalation in the care might be indicated. But these are just some of the plug and play ways in which we take the concepts that we outlined from the tobacco use disorder and alcohol use disorder, and we plug it into these very simple vignettes in a way that highlights how we apply the theoretical knowledge that we have outlined in clinical practice. And then, of course, once the withdrawal symptoms are somewhat stabilized, offer pharmacotherapy or medication for alcohol use disorder prior to discharge, together with also offering of the psychosocial treatment. So having said that, let's just put it all together. Really the key message is to make substance use disorder treatment reflexive, not optional. If you can prescribe SSRIs or treat depression, you should be able to also treat substance use disorder and prescribe medication for substance use disorder with just as much ease. And we have every confidence that you can do that. Tobacco use disorder, treat it every time. Opt out of NRTs in an inpatient setting. Medication for alcohol use disorder, like pharmacotherapy, is just like prescribing SSRIs. Just know the indications and some of the side effects, and get comfortable with it. Try it out. Offer them. Ask the patient for feedback on how they are doing with the medication and how they are affecting their ability to stay abstinent or stay in the recovery trajectory. And lastly, withdrawal symptom triggered when you can monitor the symptoms with things like CWA, or in case if you cannot, fixed or front loading to make sure that patient receive early adequate treatment for their withdrawal trajectory. So, and then just try practicing it into various different clinical vignettes, so you can get comfortable with these theoretical concepts. And the same thing can be applied to other substance use disorders, such as opioid use disorders. And that's it.
Okay, well, thank you very much for a really very useful overview of how we would approach this. I particularly like the first slide that you had, Hilary, in terms of your desire to sort of, sort of treating the whole patient, if you will. And I like to think about this in terms of presenting to the students something that we're going beyond just treating symptoms. I think we in medical school have always focused, we know how to do detox, which is treating certain kind of symptoms, but we often ignore treating the underlying disease. And I think what you have done is sort of package a broader spectrum of interventions here that deals with that. I'm particularly concerned about what difference you have noticed in terms of the students' response to this teaching. Because what you've done is clearly separate out teaching into smaller segments, rather than we're giving an hour, which is going to, present this is how you treat alcohol, or an hour on opiates or something, into what I would assume is more absorbable bits of information. And I just wonder what your experience has been in terms of the students' reaction to this teaching approach.
Well, Dr. Kim, you might want to answer that since you're spearheading a lot of this.
Yeah, so typically I break it down into different pieces, bits. So every day that we see the patient on our unit, it's a pretty fast-paced inpatient withdrawal management unit. So our rounds tends to be relatively shorter, and a lot of the patients are in active distress from the withdrawal symptoms. So we do have to move through the patient very quickly. So I try to squeeze in some pearls for each patient that we see. After we meet with a patient, I try to teach one pearl about that patient, and I would ask the students, okay, what do you think is going on with this? How would you manage this? And then the patient will have learned something about that condition. For example, let's just say if the patient is actively withdrawing from alcohol, I would ask about, okay, how would you go about managing the withdrawal symptoms in that setting? What would you use, and how would you monitor it? Or and we move on to the second patient who may be post withdrawal period and may be considering stepping down to the next level of care, in which case I might ask about pharmacotherapy, medication for alcohol use disorder. And I would encourage the students to think about the different FDA-approved options as well as off-label options and how you might apply those things to that patient. And then we move on to the next patient who may have tobacco use disorder, in which case we talk about different pharmacotherapy as well as how to go about talking about that patient, talking about that, setting a quit date, ask, offer, ask, and I would teach that. So you get bits and pieces of nuggets here and there, and then towards the end, I put it all together and synthesize for the patient, for the client, and as well for the students to put it all together, so you have a broad understanding of what may be going on. So I found that the students typically respond
very much. Yeah, you're tying it very much then to direct patient contact. I mean,
yes, because it has to do with salience or relevance to what you're seeing in front of you, and I think that's a pretty powerful way to educate and learn about and retain the information, rather than just trying to sit through a 60 minutes of lecture or trying to read the entire chapter of the textbook.
Do you find that the students retain it more directly or absorb it more effectively when you approach it that way?
Yeah, I think so. I think at the very minimum, the students remember that presentation very well, and they can quickly look up that information if they don't know that, don't remember the details. But once they see it, they will never forget it. And I think that's pretty powerful. And oftentimes what I find is that the students who see something like that ask questions, and then go home and read about that condition, and then come back with follow-up questions, tend to be the one who actually retain that information the best and are next able to manipulate that information and apply for the subsequent patient with greater ease and flexibility.
At
I
the
also
time
think
Hilary, I'm sorry, go on.
I'm sorry. I was just going to add that I think one of the things that I also think is really great about this approach is that it encourages the student, from a learning technique, it's effective, but then on top of it, I feel like it's very permissive to encourage them to spend more time with patients. And a lot of times medical students will say, we've really loved this experience because we had the most patient contact, and in other services, they're busy doing tasks to move the patient along in their care, and that this really gives them broad permission to spend the time with the patient while they're learning.
Yeah, I'm glad you brought that up, because that was the other thought that I had as you were presenting this, was that, traditionally the medical students often spend time writing up a long history on a patient and getting more details. And I think that is a very useful part of their learning. At least I find that it helps them humanize the patients. I think it helps them deal with any stigma they may feel towards people with substance use disorders. And I think that if you can couple that type of in-depth discussion or interviewing of the patient with this information, it's really useful. When you do the presentations originally, do you have handouts that you give the patients or you give the students, or as you described, is it more likely that you're going to recommend that they go read up something, or they follow up your discussion with some reading rather than giving them a handout of more details?
So the way we approach it on our unit is we give a brief spiel or description of our recommendations in a easy to understand manner. So we have some kind of ways, and we have some phrases that we use that have been time tested, and patients appreciate that they're easy to understand. And then we would answer any questions that they might have. And if they want to read further about the specific details, we'll also have some handouts handy in case if they want to read more about it. So that's how we typically approach it.
Okay. What kind of feedback do you get from the medical students about these experiences? Is there any pearls that you get back from them about how they respond to this or what they think about it? The recurrent message from the medical student have been that just seeing the patient, talking to the patient, and getting immediate feedback on how I did on the interview, and some of the teaching pearls or the information knowledge pearls in that moment was very powerful. And I think that experience actually translates to this information or medical knowledge that is going to last a long time, and a body of knowledge upon which they can build. And I think that's a pretty powerful way to learn.
I'll add to that students will frequently say that the most important thing for them to feel on a rotation is that they're useful. They want to be useful to the patient care. And so I think this is a way of framing the care that allows them to feel highly involved with the patient, but also with the clinical team, and really experiencing themselves as having a care role that's meaningful.
Do you ever find the students following up in more detail, their own personal interview with the patient in more detail to deal with some of the patient's ambivalence or deal with some of the patient's more detailed issues around their substance use?
We definitely do.
Mm-hmm. Yeah.
We actually also have a motivational interviewing training program, both weekly, and then another attending on the unit has a brief sort of computerized way of training. So these basic techniques in motivational interviewing are then practiced with the patients on the unit, and the students really enjoy that piece of it.
Sounds like they probably come out of that experience sort of learning how to talk to patients, substance abuse patients, which I think is really critical. And I really like the way that I think you have, at least I sort of grew up in an era where most of the learning was sort of you sit down in an auditorium and somebody shows you a lot of slides. And I think that we're now in an era where it's case-based. And I think the students expect that they will get some of these small vignettes that you described, and you can tie the learning as you've done to these many stories about the patients. And I suspect that that's a much more effective way for them to absorb the material. At least I think the data shows that this is a much more effective way for the information to sink in and become practical.
Another way that we are experimenting is we are actually giving ahead of the rotation some of the vignettes that we made based on our clinical experience on the unit. And I've actually created this list of clinically salient or high yield questions so they can take a look at it ahead of the rotation to get a sense of what are the important high yield topics that I should know before I walk in. So that they come in prepared and they see the different myriad presentations or manifestations of the substance use disorder, and they can appreciate the whole spectrum of the nuances in which the substance use disorder can manifest. So I think just coming in with that case-based body of knowledge has also been something that we've been receiving positive feedback about.
Do you do any post-testing of the students after they finish the rotations?
We're collecting survey right now about that experience.
Yeah, because I think we're all struggling with, how do we adapt this new student generation to this learning environment change that we have. And I think you presented some wonderful examples of how people can be much more creative and integrating the learning into what sounds like a very fast-paced rounds sort of experience for the medical students, yet it sounds like you are able to engage them in the process pretty effectively.
Yes, I think besides also just the content of medications or psychosocial treatments or information giving or withdrawal management, also the way you interact and engage with a patient could also be given feedback and taught in a similar manner. So I oftentimes give feedback about, okay, how was the alliance forming like after that patient encounter? How is it like to feel like did you feel like you were making progress in terms of patient's ambivalence? Did you feel like you were able to effectively convey the information that you were trying to convey about the medication? So some of the things that, some of the softer skills, so to speak, around being a doctor can also be taught this way after each of the patient encounters.
Yeah. I was talking to a medical student actually this morning, and they raised the question of, what do we do when we're dealing with a patient who obviously has a serious, say, alcohol problem, but their presentation to you is, oh, it's not a problem, not an issue. What do I do when I meet that kind of resistance from the patients about this? And I wonder if you find that this approach makes it easier for them to approach them, or do you have any advice to give for the patients who may be more resistant to making any moves?
I would say that, leading with empathy is always your best bet. There's a person in front of you who has probably more than one health risk or lifestyle issue, and trying to be empathic about relieving suffering in the moment. What's worrying you the most? What's bothering you the most? Start with something that creates a collaborative relationship and a shared understanding. And then you build on that. And, it's up to the patient really to make final decisions. That's what they're receiving care, but it's up to them to really make their final decisions about how they want to change their life or not.
Yeah, but I think what you're doing very clearly is you're respecting the patient. You're treating them with dignity and respect as you do all of this, and I think it's very clear that you get good responses from the patients when you do that. We just have a few minutes left. Any final comments that you, either one of you or both, would like to make to wrap up the hour?
I think.
Yeah, go ahead, Hilary.
I was just going to say, have fun with the teaching as well. Like, teaching is best when it's a fun encounter, when you can share, a lively discussion about a particular patient's presentation, and the learning is just organic to that.
Yes. And we oftentimes actually also invite the patients to comment on how we did. And many times the students are surprised how well they did in getting that direct feedback from the patients. And it's a powerfully encouraging motivator to pursue more.
Yes.
What do the patients actually tell the students? What sort of direct response do they get?
So, for example, they may comment that, "Oh, I felt comfortable talking to you," or "I felt like I was being listened to. I felt respected. I felt like the information that you gave me, I initially didn't think about medications, but the way you presented it made me think again, so I might change my mind." So those hints are very encouraging for the student, and I think it's a powerful way to engage clinically.
Yeah, no. Well, I would agree, and I think clearly the patients benefit from that. But I also think just listening to you that you are also treating the students in the same way, in the sense that I think you're approaching them with respect, and I think trying to present information in a way that's easier for them to absorb, but at the same time causes them to raise questions or think about what they're doing. So I think that when you put this all together, I think you can come up with a very productive experience in substance use that you can put in. I think you can build into any psychiatric rotation for a medical student. And I think that just absorbing this basic information is something that I would expect that any psychiatrist should be able to do, and any medical student rotation should be able to provide. So I think we're going to wrap up for today. I want to thank you both very much for an excellent presentation. I think we all got lots of useful pearls to try and build into our repertoire. And so I want to thank you for helping us.
Thank you. It's been a pleasure.
Yes, thank you to the three of you for this really insightful presentation. And I think the discussion was also valuable in clarifying the variety of points during the presentation. This does conclude the webinar, and I encourage the viewers to contact us with any further questions, to watch for upcoming presentations, and to look at some of the other teaching tools available on the copenow.org website. I lastly encourage you to join COPE and our mission. And with that, again, I thank the three of you, and to everyone, goodbye.